for many of us, many of us here in this room know about some of the historical perspectives of intensive care in Uganda. We know that the first ICU was in Mulago, and it was a renovation of an old unit. Some of my teachers are here, and they were part of that growth. And initially, the JICA, the Japanese government, had renovated, and we had British-trained anesthetist who was part of the leadership and led it for a while. Later, we had Lacho Hospital. Anyone from Lacho? Okay. Then the private hospital at International Hospital. And technically, like in many parts of Africa, these ICUs are led by anesthesia providers. So the first work was by Sarah Hodges and colleagues in the department that were trying to understand the anesthesia situation in Africa. And at that time, in 2007, I think I was in my second year of specialty training. Uganda had only 11 anesthesiologists for about 30 million people at the time. And they had one ICU-trained nurse who had been part of the Japanese initiative. She has since passed on. Later, Reitowe and Ojara from Lacho documented some of the things that they were doing. And they used to use, in desperate situations, a Gloucester vent connected to an EM drawer apparatus to deal with some of their tetanus patients. So I came along and we reported a little bit of progress at the time. This was a paper published in 2012. This paper got me into trouble with the government of Uganda, mostly because of the fact that it was picked upon by the Monitor newspaper, and some discussions were held. I didn't exactly go to the basement, but something similar. So later, Dr. Atumanya and colleagues did an update. Now, the thing that emerged in that time was that as we were slowly building capacity in terms of more trainees in the anesthesia space, the population was growing. I think at one time, our fertility rate was either second highest, if not the highest in the world. Ladies, we thank you. So the only problem was that for the growth in population, for what was celebrating as a growth in the number of ICU beds, also the population growth was matching. So as of 29, based on that report, so we decided to look at what progress we had made. So drawing on what Atumanya and colleagues had published, we had 12 functional ICUs compared to about 6 at the time of 2012. There was now plans for a 60-bed combined capacity at the Mulago complexes. We had, I don't know if Mary J is here, the first dedicated pediatric ICU. So of course, Heart Institute had been doing pediatric cardiology, pediatric cardiac intensive care. So you could say it was the first pseudo-pediatric unit, but the first fully fledged was the Mulago unit. We had improved the curriculum, the Master of Medicine curriculum at Makerere to include 1 year of intensive care medicine, because we're also cognizant of the fact that it was going to be difficult for everybody to keep going for fellowships and training abroad. And we had about 12 collaborative research and training projects for various aspects. And then Busitema University had started its MEd program. I don't know if Adam, Fred, and JP are here. I think I saw Adam is hard to miss. And kudos to them for bringing that's this far. And then Mary, JT, and colleagues had also had pediatric training, and Richard as well, in pediatric anesthesia and pediatric intensive care. There was a pediatric critical care curriculum under review. I don't know how far that went, but the idea was for it to be held under the auspices of the Department of Pediatrics at Makerere. And of course, over time, there was diverse capacities to perform some of these procedures, advanced procedures that we didn't have at the time. Then COVID happened, but it also gave us momentum. Suddenly, the government that had been ignoring us started to call us, Dr. Kwizera, where are you? Are you in Cambridge? Or, wherever. So, as luck would have it, we managed to become relevant to the space. And that's where everything picked up. Initially, the plan was just to develop Uganda's ICU surge capacity, but we prevailed upon them to actually think much longer term. So with AAU was very lucky that we led the efforts in terms of training, preparing people for surge. I want to credit Dr. Laro because he sort of saw this thing. He's a surgeon, and I think he sort of realized that, there's going to be life after COVID, and he accepted the challenge to allow us to dream bigger than what they had initially thought, because as there was so much short-termism in the things that were in the way people were thinking at the ministry. So in terms of preparing for that, we got some equipment that we got from different sources. Many of you know these gradient CCVs. We went around the country training and setting them up. At the time, it was difficult. It was the only available ventilator, and the government was very keen on showing that they had done something. Do we have any government officials here? But anyway, we are the government. That's what they will tell us. So, whilst there was some sort of resistance, my goal was to ingrain into the mindset of the leadership that even if you're getting a ventilator, this ventilator is here to stay. So it will get old, get replaced, but then we will make sure that now in country we'll have a structure continually for intensive care. And the mindset change was the biggest lesson that I had, because as many of you would have known, people had a different idea of what an ICU is. And that's why I got into trouble 2012, because you're talking about functional ICU, and then the minister tells you, no, we have 2,000 ICU beds. What are you talking about? Why are you telling lies? And then I said, I asked her, did you actually read the paper? She's like, no, it was reported in the Monitor. I'm like, maybe if you read the paper, we might have a different understanding. And we are here now. So it was a good thing in that respect. So AAU members traveled around the country training people. We knew it was a stopgap measure. And then COVID came. When COVID came, it was very difficult. I think the first 2 patients that died in Mulago, I think I was the one on shift. And it was like nothing we had ever seen before. But during that time, we were able to sit. I think some of the guys, Cornelius and Tim, were able to sit and start to engage with the folk at the ministry to allow us to plan for life after COVID. All of us, medical doctors, researchers, we've never been involved in capacity building from a whole planning, health system strengthening aspect. So we're really learning a lot. Someone will sit and tell you it's not how things are done. A policy document, meanwhile, takes 5 years for it to, from the time you actually start having meetings to the end, to when it becomes policy, and then the Minister of Finance can start funding that policy. Now, we guys would think that, no, it's common sense that you just put an ICU, we go. It wasn't that straightforward. So we had to go back to the drawing board. Dr. Evan is here, he'll tell you how things work. We had to go back to the drawing board. At the ministry, there were things called technical working groups. There were all these meetings that involved chai and mandazi, right? And you had to sit and work through things which you would do in 30 minutes, but they would take a week. So you had to develop patience. And you had to decide that, okay, this is what I'm going to do. This is what I'm committed to doing. And you have to take leadership in it because no one else is going to do it. So luckily enough, we created the technical working group for intensive care and oxygen. And I was happy to lead that. And the goals were that by 2028, we would have 32 intensive care units, public, worldwide. And then, of course, at the time, an additional 140-bed complex. But at that time, it included also what the Uganda Heart Institute had planned. So along the way, We also developed, in partnership with colleagues in Cambridge, what we call the Scale Critical Care Program. Some of you have been to Cambridge for your fellowships, and there's an opening for August next year. And we are learning a lot of lessons. You go spend a year or two, 18 months, and then you return. And when you're there, you're salaried, and you're working like as a fellow. And then we decided to take leadership for the oxygen scale-up from the ministry, and we started working with Path and Chai to lead the national scale-up plan. We published this work in one of the critical care journals because we also realized that there are many African countries that didn't have a blueprint on how to go through this. We had some pretty clever people in the room who taught us about frameworks that involve capacity buildings, and this is the framework that we modified to build capacity. So aspects like organizational development, workforce development, resource allocation, partnerships, and leadership. And then we then use these aspects to create the domains that followed. And those domains determined our work plan. So the first thing we did was to assessment of human resources for critical care provision. Now remember that whilst having intensivists is something aspirational, the minimum person that should handle a critically ill person is an anesthesia practitioner, whether be they a bachelor, be they a diploma, or be they a physician. And so we had to focus on the core skill sets that are required. So then, and this is, of course, this also included nursing. Then we did an assessment of the infrastructure for critical care services. And then, of course, the other big issue, the elephant in the room that continued to hurt us, was oxygen capacity. So we then looked at the scope of practice. Andrew and Fred and Adam had helped us lead, and other people, on the scheme of service and scope of practice aspects for anesthesia and intensive care. And not to forget our nursing colleagues, because these guys are the lifeline of intensive care. We found that there were about maybe 50 dedicated ICU nurses for 11 ICUs around the country. Many of them had mixed training experience. Most had learned on the job. And Mulago alone needs 225. And we're only talking Mulago Hospital, the national specialized. We also realized there were no formal ICU training programs. There was only one master's program in Barara. And then there was an in-service training that was done quite haphazardly in response to COVID. So like I've said, mostly was on the job and in-house mixed training by visiting nurses, from doctors and so on. People learned on the job to get these skills. So there were plans by one public and one private university to start diploma programs. So when we were doing, I've started the human resources aspect. So when we were doing the human resources aspect, first of all, we had to get the Ministry of Health to approve the new scheme of service in terms of service of the Ministry of Health mandate for service provision. And we were very lucky that in one of the very early meetings during COVID, the Minister of Health asked us, so in terms of response, what should an ideal ICU situation at a regional referral hospital be? And I didn't waste time because you don't waste those chances. Said 10 ICU beds, 20 HDU beds, make sure there's dialysis, make sure there's an emergency department, make sure there are at least 3 operating rooms. Then she's like, yes, go ahead. She told the police guy, make sure that is now. So she did something a bit top down. We shall know later whether it was a good idea, but it helped us move forward. So with the human resources guys, we sat down and we got an HR consultant to give us pro bono services, because the ministry will tell you there's no money. So we sat, and she's been helping the association as well. She was a human resources person in many of their private hospitals. And this was the methodology we used. Okay, the Cavallo is too much, but essentially the whole idea was to determine what we call full-time equivalents for each of the positions. So if, let's say, I broke it down, I don't know if you can see. Mine is clear. Okay, at the end of the day, all I want you to see is that a a full-time equivalent is basically one person to cover a shift. So we found that for your 10-bed ICU, or for the theater, if you have one OR, and that OR is working 24 hours a day, 7 days a week, then that meant that you would need to have 4.2 people of positions and so on. And essentially, when you factored in leave, maternity leave, sick leave, and everything, this led to the number of positions that would be needed at the facilities. So in this case, we're talking about 10-bed ventilated ICU beds, and we're saying 2 dialysis beds. So we had the nurses. So within the ICU, you had anesthesiologists, anesthetic officers, assistant anesthetic officers, and so on. So we talked about shifts, we talked about all this. But let's just say that there was a method to this madness. So as a result, we presented this to the technical working group on human resources, and the new public service structure for health now has, let me read them out for you. So for emergency medicine, you have 1 position for a consultant, 3 positions for MOSG, 8 positions for medical officers, and so on and so forth. For critical care nursing, you have essentially 55 positions for critical care nursing at every level for every regional referral hospital. And then for perioperative physicians, basically for anesthesiology, you have 29 positions. So that was a very big jump from what was previously there. And so what that means now, the next hurdle was that now that this is established, the directors of the regional referral hospitals, subject to a very common word they will tell you called wedge, can then prioritize recruitment, because now there is a policy and there's a structure for recruitment of this cadre. So we were able to do that work in 3 years. There's still work in progress because they will tell you there's no money. And there are things I want to say about that, but the basement is real. So of course, the last bit, the other thing that we talked about was oxygen. So I'm not going to take you through that, but we came up with a formula of how to determine Uganda's national oxygen needs. So this was now part of the National Oxygen Medical Scale-Up Plan, for which I was the technical advisor and consultant for the ministry. So we devised a plan to determine the national demand. This is math I don't want to take you through. But essentially, we imagine a scenario where you have both a pandemic, a respiratory care pandemic, like we had COVID. Now we have intensive care units. Then we have NSOPs. Now, obstetric patients, trauma patients, patients with critical illness that have community-acquired pneumonias, children, all the scenarios. And this guided the procurement of the oxygen plants that we now have at all the regional referral hospitals, and we are also able to budget for it. So Uganda needs to spend about $30 million a year on oxygen, on the whole oxygen ecosystem. This includes procuring oxygen therapy devices and so on. So the minister signed this scale-up plan. It has 2 components. One is the oxygen scale-up. The other one is equipment guidelines, equipment management guidelines. Dr. Tendo, Dr. Tindi, I think, were on the NACME, the committee that dealt with the equipment guidelines plan, and the minister signed it off during the National Safe Motherhood Plan. So the big lesson was that if you want something done and you have to do it right, you've got to go through what you think are the bureaucratic steps in government so that it gets locked in. Because now if I went to my friend, the PSST, and I said, Rama msajja wange, kakati tuine chizibu, Mbale, he will just say, is it in the policy? Is there a policy? I say, yes. Can the PS sign off? Yes. And then tomorrow he'll send money. Okay, it doesn't work easily that way. But the point is that now we have a blueprint that can be referred to. If we got oil and we only used a third of it well, all of us will have jobs in all the regional referral hospitals doing the things that we love, but we have a document that can support that. Now we shall plan for that oil. So, of course, the next thing was, what about infrastructure? So in the committee, there is a health and infrastructure division technical working group. You're going to hear that TWG word quite a lot. And in that meeting, we then sat down, and there was a bit of back and forth on the design plans for that building. Anyone from Hoima? Anyone from Arua? Anyone from Kabale? Okay. So these were the places that eventually got the first buildings, and I'm sure you might have read about them. So these buildings are under construction. In this building, you're going to have 10-bed ICU ventilators, 20-bed HDU with mostly high-flow oxygen therapy, so on and so forth, for every regional referral and select hospitals. Now, some of you might have seen this map, but the overall plan, this was supposed to be 2026, but now that's next year. So I don't want to sound like a government official, but there are nice words we say that explain why that won't happen, and it's a resource envelope, and so on and so forth. So the goal now is 2028. At least 3 referral hospitals now are now under construction, and this will happen maybe over the next 3-4 years. But there's a blueprint for human resources, for oxygen, and also for construction of these services. Many of you know this. So this is obviously the Mulago ICU, but a lot of the blueprint was based off of the lessons learned from the ICU. I'm one of those guys the people tease that I want to have ECMO, I want to have what. So I've learned to tone down my ambitions, and that will be for an ICU that I run myself, God willing, one of these days. But yeah, we got some of those lessons and inputted them into the infrastructure plan. So remember, I'm talking about what seemingly works. So I've given you some progress today. But we are stopping at the regional referral hospital in terms of planning. So because I am not 100% upstairs, I decided, you know what, but can't we do something at the district? And so I went to the PS and said, but what about the district? And they're like, Arthur, aren't you satisfied? I said, no. Because even in the villages, people die. So if we have an opportunity, then she's like, well, you go and do your thing, go and do research, and see what's. Then she asked me, what do you want there? I said, I don't know. We don't know what happens at the district, but there are people who are willing to work. If we give them some skills, then we came up with an idea, what we call the community critical care concept. And we learned something. We had just concluded, we've just concluded a clinical trial. 17 hospitals around the country, and we're just comparing. Because remember, if you needed oxygen, if you're very, very sick, this one will tell you, intubate, right? So you get intubated. So because there's nothing in between. You're either low flow with 15 liters per minute and then straight to the ventilator. And that's if you're lucky to have a ventilator. That was something else. So the hypothesis for this trial was, can't we have something in between, and can it reduce lives? But the first question I was asked at ethics, at the ministry, was, but aren't these things supposed to be by ICU doctors? And they were right, because abroad, in the UK anywhere, you cannot prescribe advanced respiratory therapies if you're not a respiratory physician, an intensivist, emergency physician. You have to be at a specialist level. But you remember, we are about 50 years away from saying we have enough. And even I am being optimistic. So I said, no, why don't we test this and see if we can actually have medical officers, anesthetic officers being able to do what people in high-income countries do as specialists. So we did the ARISE trial, basically. Let me see. So that's the Buzniak CPAP system. That's on the right. That's a patient who is having advanced oxygen therapy with the Buzniak CPAP system. They would have needed mechanical ventilation by all the criteria, and they made it out alive. The patient the next patient is a patient on high flow nasal. I think at the back there is I think we had Fisher and Paykel. They are the Mercedes-Benz of high flow oxygen therapy. So both patients survived. Both patients would have needed mechanical ventilation. And so at the end of the day, we now had something to work towards. The trial was done, and we proved the first thing is that these patients, that you guys, medical officers, anesthetic officers, can actually provide some advanced form of respiratory care in a very resource-limited setting where there's no access to intensive care. So there's a concept that I call the chain of survival in critical care. And the idea is that at every level, borrowing from the chain of survival in cardiac arrest management, where nowadays when you go to those high-income countries, you'll find an AED on the wall. And so there are many lay people who know how to use an AED and to do CPR. And that is what they call the first responder concept. So we said, in the communities, in the villages, can't we get these VHTs, these community health workers, to also get additional skill, anything, even if it's just recognizing this patient looks unwell. So I have a story. In 2022, my father passed away. So I went to talk to the VHT who had managed him in Kisoro, in the village. And Dad had gotten sepsis. It was not very well managed, obviously. And the first thing that hit me was like, this is how people die. So I get this VHT guy, walk to the hospital. And at the hospital, there was a patient who was on oxygen with an oxygen concentrator. And so, as you know, our district hospital wards, I want you to think that image. And so I had a pulse oximeter. And because I really wanted to understand, because when my father fell sick, he had a tooth extraction, and it swelled, he got fevers, he went to him. In Africa, when an adult comes to you with a fever, what do you do? What do you treat? Malaria. So the VHT gave him malaria, anti-malarials. He went home. Dad calls me. I said, okay. I didn't think much about it. The following day, he wasn't feeling better. This time he goes back to the VHT. The VHT thinks that this malaria might have gotten worse, sends him to the hospital. But Dad said, I'll go tomorrow. Gave him some paracetamol. He felt better. In the middle of the night, Mzee has convulsions. Managed to get him to the hospital. In the hospital, did a CT scan, managed to take him to a CT scan. Believe it or not, in Kisoro, there's a CT scan. In Mutole, it's a private a PNFP, and he had meningitis. And so put him on oxygen. We started planning to airlift him and so on, but it was a little too late. He went to be with the Lord. So when I spoke to the VHT, because I really wanted to understand, because something was starting to form in my mind. I brought him to Kisoro, to the emergency ward. So I put a pulse oximeter on the patient, and the reading was something like 83%. And that patient, those concentrators, their max flow is 5 liters per minute. There are some of 10, but most common are 5 liters per minute. And so I put it on it's called, I think it's Dismas. So put it on his finger, and he was like 94, 95%. So I asked him, so what do you think is going on here? He looks and he says, well, whatever it is you're measuring, I have more. So I was like, okay, that's a good start. So this guy was on 2 liters per minute. I cranked up to 5 liters per minute, gave it a few minutes. We talked a little bit, came and measured the patient again, and he was like 89, 90. So I asked him, what do you think has happened? He said, well, whatever it is in that machine has something to do with this rise. I was like, okay. I asked him, do you know oxygen? He's like, yes. So I said, this machine gave him oxygen. He said, no. So in the corner of that ward, like in many wards, there was some abandoned oxygen cylinder with the cannula, nasal cannula hanging on the side and so on. He said, that is oxygen, not this. I'm like, so when I tried to explain to him that this machine sucks air and so on and so forth, and then gives you a concentrated air. So I asked him, but do you know oxygen very well? He said, yeah, COVID medicine. I'm like, okay, we're getting somewhere. So I gave him the pulse oximeter. So I told him, if I give you this device, how do you think you'll use it? He just said, I'll make money. So I said, okay, that is not bad. So we did a deal. I spoke to the medical officer on the ward. Actually, it wasn't a medical officer. It was a very smart emergency volunteer. And I said, this guy, I'm giving him this pulse oximeter. He's going to be... And then I told him, please don't charge more than 100 shillings. He said, it's okay, I'll do it many times. I said, fine, that's you. So I said, I gave him a post-it note pad and said, for every patient that when it gets 91 or below, send them to this guy. That was August. So I return, we get a grant because now I have an idea of the ICU situation in Kisoro. And because I'd spoken to the PS, I returned in November to do planning for redoing the ICU. And when I got there, I'd even forgotten. Then the EM guy says, "You forgot." I said, "Oh, yes." And he had about 186 referrals from that PHT. All of them SpO2 91 or below. And I asked about them, what happened. I said, well, many of them survived, some died. I was like, okay. So a thought process formed, because that meant that something about early recognition could be done, even by lay responders. So this is when I talk about the chain of survival. You start in the village, then you come through a healthcare system, and then when you even go back to the village, we have to think about post-discharge physiotherapy, community engagement. Now, of course, this is a dream, but everything that happens starts somewhere. So we got some money from somewhere. Old man had also left me a bit of fair change. We remodeled. We got some really smart AO and MO, and they came and did training with us. The association ran a course called Basic at Mulago, and they started work. Some of them are in this picture. I don't know if any of them is here, but we had Jen Frida, we had Dr. Martha. So they learned high flow, and we also made sure that Kisoro was also one of the sites for RISE, because I was curious, plus it's my home. So I will not lie about that. We then went ahead to actually do a few things. So Dr. Martha and team came up with a few case reports, and I don't think it's clear, but in this case, you had a 49-year-old patient who presented with sepsis, but pneumonia as a focus, was on the ward, had a respiratory rate of 37, was 88 to 92% on 15 liters by non-rebreather face mask, was a pre-diabetic hypertensive, poorly adherent to their medication. Anyway, the patient, the diagnosis was sepsis. On the third day, this was one of those progressors to mild to moderate ARDS. And the team started the patient on high flow oxygen therapy, and continued treatment for the sepsis focus. There were episodes of desaturation. The patient continued on oxygen supplementation with high flow and hourly suctioning and prone positioning, to titrate the patient down with improvement. Anyway, long story short, they survived. And if they had not had access to high flow oxygen therapy, they probably would have died, because they couldn't even, they couldn't afford a referral to Kabale, which had the nearest ICU. 2, we don't know what would have happened if they had gotten to Kabale, a regional referral ICU, because they have maybe 3-4 bed functional unit, and they might have found the beds full, and we don't know what would have happened. So that was one big lesson we learned that's now starting to become a focus of what we want to do at the district critical care level. Perhaps we can't do, and we shouldn't do, mechanical ventilation in districts, and I think I'm more inclined to having the advanced non-invasive respiratory therapies as being the mainstay, along with other bundles that we are going to continually research around. We presented this to the ministry, and now we're going through the technical working group thing again, so that we empower districts to have a district level HDU, pseudo ICU type scenario that can reduce the burden of referral and improve outcomes in the pathway. So we can't do a lot without generating our own evidence. So as we build capacity, we also need to be able to generate evidence that can be used in our own setting. A lot of the studies done in the West don't apply to us. And there have been quite a number of examples, especially in fluids and sepsis resuscitation. So just the other day, we started an African acute care and clinical trials network in Kigali. I'm the founding chair for that. So we had about quite a number of attendees from Africa and from our northern partners who have set up trials groups around. And it will be headquartered in Rwanda for obvious reasons. And we've already had an opportunity for the first grant that will help us build capacity, and we already have a position statement, and there will be an invite to everyone, because this is for everybody who looks after an acutely ill person. A lot of trials and registries and so on are based in an ICU setting. But we know that 99% of our critical care, our critically ill patients are actually outside of the ICU. So this is going to cater to everybody. As we build capacity, its own capacity, there are going to be some opportunities for helping us build clinical guidelines. The association is already doing clinical guidelines for anesthesia and intensive care for Uganda. Then research training, capacity building in that area, and helping other centers of excellence grow. It's not supposed to replace whatever else is happening. You know, the EECC, all those people, APOG and so on, are members of a network. The network's role is not just get resources, but also to connect people to the opportunities that are ongoing. So, of course, what are the challenges? We learned many things, that the global supply chain is difficult. Procurement is a problem. When we were redoing Mulago, Dr. Tini, it took us how many years? 6 years? 7 years? To renovate Mulago, this new renovation, and yet we were supposed to have done it in 2 years. So there are always going to be challenges. We have plans, what they call the best well-laid plans, but execution can be an issue. Funding. We're going to pipe oxygen around at select about 25 district hospitals. And that idea was mooted during our first meeting, but the money is just showing up now. And they're saying, oh, no, you should finish this project in 6 months. So those are things that you learn. Then, of course, we all get tired. We are still very few in the things that we do, and you're always going to have challenges with these things. So all I'll tell you guys is in your sphere of influence, as long as you have an ear, you learn to develop relationships, you can create the change that you want within the space that you are. We know that we're going to have a growing population if our ladies here keep going at the pace they're going. And so what we need to do is basically work together and also work with the government to enable them support us, and we support them in growing these things.